Okay, guys. So we'll just start off. Thanks for those who are joining. And basically, what I'll do, just do share screen, and we'll bring on the today's presentation. Just hold on one sec. Okay. Let me bring share screen on this, right? Just let me know when you can see it there.
Yes.
Yeah. Okay, that's good. So just loading. Okay. Okay, everyone. So thanks for those who are here. That I guess the challenge here is to get the questions done on time. Okay. The challenge here is to get the questions. We are going to do data interpretation questions, various mix of questions. Some of them will seem very stupid, very simple. Some of them will not be that simple, because in the exam, what we found, what are the common things happen? What are the common problems which happen when we go in the exam? We make silly mistakes, isn't it? What do you think? Okay, I just want to see your passcode for Slido. Okay. Passcode for Slido is brainstorm. Okay, so I'm saying more than how fast we can answer that. Obviously, the way I've designed it is there are a bit of explanations, there are a bit of description about questions which may arise around the STEM question, which I've taken, believe me, a lot of time trying to get those those bits of information, so that the next time in the exam when you come to it, you will get questions around that, you can answer that. Okay, so that's how I've designed it. All right. So it's a question of application, how you can apply your knowledge to the questions. Okay. So with that, we'll get started. Is everyone on Slido? Have you got your slido.com? Just put yes on the on the chat, the Q&A box. Just put yes if you got your Slido. Just go to slido.com, #brainstorm, and join as participant. That's all you have to do. Just type yes if you've done that. Hello there. Are you still there? Hello.
Sir.
Yeah. Can you, one second. Yeah, can you see?
Yes, sir.
Are you there? Okay. So just let us go through this, and then are you on Slido? Have you all got your Slido thing? So Tirthendu, you wanted to say something? Okay, Tirthendu, what you wanted to say? Something you wanted to ask? Yeah. You can say something. There's something you wanted to ask, Tirthendu. You put your hands up. That's right. I think let us get started. Okay, otherwise we'll take a lot of time. Okay, so to all those here, Runa, Krishna, Soma, Deepa is here, Geeta, Krishnendu. I think let us get started. Okay. So the question, I hope you've seen the question. I'm just giving to answer very quickly. You can, as I said, to interact, please, the Q&A, you can put your thing on the Q&A. As I said, just to see that everyone is with me, can you, can you, let's see. So you have got, okay, Geeta has said doodle atresia. Okay. So what I'd like you to put your answer to is, first of all, everyone there on Slido, please, yes, please put on the Q&A, please type yes. Geeta has typed, Deepa has signed, but I don't know what about the others. Can you type yes on the Q&A, please? Tanushri has said yes. Okay, we will move on to the, because what happens is Slido is much easier. So this is the X-ray. Okay. Already some of you have already given the answer. What do you get in this? What is the typical appearance for these? What is the typical? Yeah. These are the choices, obviously. Give your answer here on Slido. It will come up here. Go to Slido and please. Can you do the Slido? Double bubble appearance. That's exactly. Tanushri, absolutely on the spot. And it's because so many which are very Sorry about this bit of mishap, so a bit of connection problem. Sorry about that. I'll just start sharing the screen again. 1 second. 1 second. Bit of problem with the screen. So share the screen. There you are. Hope you can see that. Okay. Okay, then. So this was the question of delivery. Woman noted to have large volume of amniotic fluid. So that is polyhydramnios. 6 hours regurgitating small amount of mucus and bile stain fluid. So the polyhydramnios, you have to think what are the links with polyhydramnios. Okay, duodenal atresia is linked with polyhydramnios. Bile stain fluid. Where do you get bile stain fluid, in which surgical conditions, and which surgical conditions you do not get bile stain fluid? That is the one you have to think about. And physical examination infant is normal, abdominal X-ray is found. Okay, so now we move on to the X-ray. You can see a double bubble appearance. Okay, so duplication, pylori stenosis, esophageal atresia, duodenal atresia, midgut volvulus. All right, now so you've got, it's not very often what happens is we feel that okay, so can you put your go live, easy, go to .com. One second. Yes. Okay, so we've got this now. I hope you can see it. So the first thing here is polyhydramnios, and then we says the bile stain and vomiting of the infant. So that is significance. It is obstruction is distal to the ampulla of Vater, so that you eliminate esophageal atresia and pyloric stenosis from consideration. That is the main thing. Okay, the very fact that it's bile stain means you eliminate these things. Okay, that it is obstruction is distal to ampulla of Vater. That's the first thing you need to do. So eliminate esophageal atresia and pyloric stenosis, because here you don't get bile stain vomiting. Double bubble sign is very characteristic, but you need to keep on seeing lots of pictures to get used to it. So that's basically the thing of it. But you need to have some idea. We need to have some idea about what other things are. So midgut volvulus, so it's not enough just to know double bubble atresia. That's fine. Everyone knows about that. It's very straightforward question. But you need to know about the other things. What about midgut volvulus? Well, it obstructs the bowel in the area of duodenojejunal junction, and in a 3 to 4-year-old with, again, here also it can get bilious vomitus. So next time the question you might get, so don't be too happy if you got duodenal your answer correct. Don't be too happy about it, because probably the next time is not going to be that straightforward. Probably the next time it's going to be mid-cut volvulus. Okay. So again, next is gastric duplication, but it does not produce intestinal obstruction. It is cystic mass. So, and the question in the exam, what happens is you will get these things like gastric duplication. A lot of us don't know. Everyone knows double duodenal atresia, double gut, double overbridge. But what about mid-gut volvulus? These are the questions, and your next question, you will not know what the answer to these things. But if the choices have come up in the exam, means that you need to have some basic idea what these things mean. And obviously, duodenal atresia, always the question will be around things like other conditions like Down syndrome or heart disease. Okay, so let's keep that in mind. So as you can see, this is double bubble, very good diagram. All right. And again, double bubble, you can sometimes they make you a USG as well. So you can see the double bubble, how it looks like, duodenal atresia. But get used to seeing as many pictures of double bubble as you can. For any X-ray, you have to see lots of X-rays of the same thing to get used to the pattern, otherwise you may miss it. Now, obviously, what is the treatment for it's for double bubble? It is Ladd's operation for correcting malnutrition, but the main operation is surgical bypass, which is called duodenodenostomy. So next time you might get that sort of question. What is duodenodenostomy? It's quite a long word, but just be idea. Obviously, Ladd's operation is the operation where there is associated malnutrition, which has to be corrected. Just be aware of this, because next time the question might be around that. So what is this? This picture of this is basically a duplication cyst of the stomach. Just be idea. This is how it looks like on USG. This is how it looks like. And gastric duplication, more common in females, where it happens in curvature, posterior wall. So that's on the back side. Greater curvature or posterior wall, mostly cystic, and there can be at times there is no communication, presence is vomiting and GI bleeding. How do you diagnose? X-ray, ultrasound, GI contrast, CT. Treatment, resection, drainage. Sometimes they do partial resection, mucosal stippling. So be aware of these things, okay? And it is a rare congenital abnormality which is suspected in neonates with GI obstruction. Also, there can be future malignancy, so surgical resection is done. And obviously, you can do a radiology is the can help in diagnosis, ultrasound, and histopathological specimen. Now, what are the signs and symptoms of esophageal atresia? This keeps coming in the exam all the time. Their question might be that frothy white bubbles in bed. That's how esophageal atresia will present. Frothy white bubbles in baby's mouth, coughing or feeding, blue color of the skin when your baby is feeding because choking, difficulty breathing. And let me give you a small story which you'll never forget. It was my first very early days when I just started doing my what do you call a job as a neonatal intern in a major hospital in Calcutta, and very new. And I remember that there was a baby which came in at night, middle of 12 o'clock at night. I was very new, and this was what they came with. It was diagnosed about 7-8 days, I don't know, quite a few days later on. It was misdiagnosed, and that's how it presented with frothy white bubbles in the baby's mouth, coughing or choking when feeding, and difficulty breathing. And I can tell strongly that even now in best of centers or in major hospitals, it is one of the commonly missed things. It sounds very obvious in textbook, it looks very easy, but unless you think about it, you may miss it. So be aware of esophageal atresia, frothy white bubbles, coughing when feeding. How do you diagnose? You just put a radio opaque tube inside. There's a special tube, but even if you put a NG tube, you will see it's coiled and it's not going down. That will give the diagnosis. But ideally, there is a radio opaque tube which you put down, and you will see that where it stops, it does not go further in. That's that. So this is the one. Even if you put a dye in, there it is, gets stopped here. Okay, radio opaque tube or dye. And these are the different types of esophageal atresia very quickly. And as you can see, the most common is type C. So just have an idea what is the most common type. This is the one where you can see the stomach going to the, communicating with the trachea. That is the commonest type. And the trachea cannot communicate. Sorry, this is the one. Sorry, here again. Sorry, bear with me. Oh, sorry. Just one second. Least common is the proximal tracheoesophageal fissure. This is the esophagus, this is the stomach, and this is the trachea. Okay, the commonest type is where the, see, in most cases, let's say, you can see, basically the commonest type is where the stomach does communicate with the trachea, but the esophagus does not communicate. And this is the very common one. Just remember this one. Okay. Midgut volvulus, so this is how it looks like. This is how it looks like. These are large bands. So it is associated with malrotation. So you will have to get rid of this as well. So this is how sometimes malrotation or, a midgut volvulus might look at. You might have to do a USG or an X-ray. Just be aware about this feature. Now the next question. Again, I would like you to actually put your answer on Slido. I don't know what's the trouble, why you're struggling with the, So the question answer is, again, you can type your question answers here. Okay, just say hello so that I know you can, and I will answer it. I'll just see if we can answer that. Okay. So you can put question answers. I've got it open here, and I can see that. Okay, can you see the question? The question was ultrasound. I'll make it simple. A routine ultrasound, prenatal ultrasound shows a male fetus with meningomycil. 24-year-old primary gravid mother is that told that the infant will require surgery after birth. Now you counsel her about the etiology of the defect and the risk of further pregnancies being similarly affected, and state which following. So there is one answer which you have to say. So just natural diagnosis can be made by the detection of very low levels of alpha-fetoprotein in amniotic fluid. Number two, subsequent pregnancies are not at increased risk compared to the general population. Number D, supplementation of maternal diet with folate leads to decrease in incidence of the condition, and neither environmental nor social factors have been shown to influence the incidence. Okay. So obviously, Agita, you made an answer, which is D. Anyone else? What about the correct answer? Okay, D. Can you use the Slido? I don't know why people are not wanting to come on Slido. I spent a lot of money on it. I had to buy, it's not free. I had to buy this Slido, online. So why don't you try at least? One participant is trying. Out of 6 people, it's not that difficult, is it? You just have to go to google.com. So Google, go to slido.com and then put brainstorm. Hashtag brainstorm. It's as simple as that. So, folic acid supplementation is true. Anything else? So it's right. It's a very straightforward answer. So this is the single gene, but it is not. The answer is D. Obviously, the defects due to single gene are designated autosomal or X-linked, depending on whichever affected gene is involved. But sometimes there are multifactorial origins, such as neural defects, and they do not conform to the normal pattern. So there can be multifactorial origin, and that's why you need to be aware of that. And relative of person with disease of multifactorial origin have increased risk of having similar abnormalities, which you be aware about. Now the risk of this one increases with each child, unfortunately. The recurrence risk for most single primary important for you to know. The next time you might get a question, the question might be this. The increased risk forms the basis of assuming that genetic factors play a role in the occurrence of these abnormalities. Other factors, race, sex, ethnic and racial background, which is abnormality of, they also have a role. The prenatal diagnosis can be diagnosed, and as you all know, it is because of increased alpha-fetoprotein, which will diagnose the anencephaly and meningomyelocele. And reduce the neurotube defects, you give 400 to 800 microgram of folic acid daily. So that's good. That's straightforward. And that's the picture. You can see meningomyelocele and meningocele. So that's good. Let's go to the next one. Very straightforward. Well appearing, about 3.2 kilo baby black infant is required. Is noted to have a fifth finger side, post-axial polydactyly. The extra digit has no skeletal duplication and is attached to the rest of the hand by a thread-like instrument. For this condition includes what? The chromosome analysis, excision of extra digit, skeletal survey, echocardiogram. So you can see the diagram. So obviously diagram is, it's basically it's just a post-axial thing. But anyway, do you know what the treatment is? Extra digit. There's only one person who's doing the Slido. I'm so disappointed. Can everyone else try it? Go to slido.com and do #brainstorm and join as participant. Two people are joining, that's a bit more encouraging. So let's see what's coming. Post-axial. So you have decided post-axial at the diagnosis can matter. It is, you don't have to do things. When you get so I will just connect one. Just hold on, guys. Sorry. Thanks for infinite patience. We'll just the screen. So you can see the thing. So what you need to know is that, first of all, the answer is B. Fifth finger or post-axial polydactyly is 10 times more common than in white children, a typical familial. The finding is otherwise black children should raise no special concern. White children, careful examination of the cardiac system is warranted. Or thumb side or pre-axial is thumb side. So thumb side is pre-axial. Is the other side. Okay, this is post-axial, this is pre-axial. Thumb side is unusual and should be further investigated in an ethic. The child cardiac examination is echocardiogram is required, but in a black child, it is not that. You don't need further investigation. It is familial. Okay, so that's what it's saying. Syndromes which are associated with it. So this is very important. What are the syndromes associated with polydactyly? Trisomy 13, that is Rubinstein-Tabes, Meckel-Grubber syndrome, and Ellis-Van Creveld syndrome. These syndromes do keep coming up in the exam. You need to know about this. Now, simple post-axial polydactyly without bone involvement may be surgical removed. So basically, they say tie up with a string, but nowadays I think you just remove surgically. But be aware of these syndromes which are associated with polydactyly. Okay, so this is the pre-axial. As you can see, on the thumb side is called pre-axial. Central is if you got in the middle. Post-axial if you got an extra one on the side. 4, 5, and then extra one. Okay, and here again it's one extra finger here. 1, 2, 3, 4, 5. So this is one extra finger. Okay. Now have a quick look at this question. Previously healthy 19 months old child woke up with weakness in the left side of the body. Weighted T2 weighted flare MRI was done. What is the diagnosis? Have a look. What do you think it is? Again, please try to use the Slido. What is the diagnosis in MRI brain? Please try to use this. Don't, you make me happy. Let me feel that the money was well spent. Yeah, one person is going there. Please, others, Tanushri, everyone, can you try to use the Slido? Go to slido.com and do #brainstorm. And don't worry, I can't see who's answering. So just answer. I can't see who's answering. So it doesn't matter even if you give a silly answer, it doesn't matter. Okay. So just type. Don't think that I cannot see who's answering. So it doesn't matter. That's why you're here. You don't see who's answering. So just put anything. So only 2 people there. Please, 3 people. That's more encouraging. So as I said, I cannot see who it is. So no one is here to judge you. I can't see who's answering. Anyone can just type answer. I cannot see who it is. So 3 people answering. 1 second. Infarct, stroke, abscess. So that's good. Infarct, stroke, abscess. Any more? 3 people. Any more? So it was a ischemic stroke. Okay. Obviously, it was not encephalopathy, meningitis, or astrocytoma. It was a stroke. Okay. So get used to seeing MRI at different types. All right. So let's move on from there. A 14-year-old presented with tonic-clonic seizures over the preceding 6 months. ECG showed generalized subclinical epileptiform discharges. It is recommended to start him on lamotrigine. Now, what advice will you tell the parents? So lamotrigine may be associated with excessive weight gain, with generalized skin rash develop. They should seek immediate advice. Mood changes is a known side effect which will require withdrawal of the therapy. Measurement of the level is required for monitoring the treatment. Monitoring FBC is required for the initial treatment. Which one is the answer? Lamotrigine may be associated with excessive weight gain. If skin rash develops, then ask immediate advice. Mood changes, require withdraw the therapy. Measurement of level for monitoring and fluid blood count. What is the advice to patients? Please just type in again. As I said, I can't see who's typing. So just type your random answer. Just type random. Because in the question, as in the exam as well, you have to get used to committing a decision. Don't stay away and don't be used to not making a decision. Because in the exam, there's no negative marking. There will be no negative marking. Okay? There will be no negative marking. So basically, number 2, that's right. Generalized skin rash develops, they should seek immediate medical. That is the most important thing to tell to parents. Okay, so very good. What side effects may I notice from receiving this medication? So that's just a bit of information. So there might be allergic reactions. So that is the important thing. Vision, fever, neck pain, heart rhythm changes, irregular heartbeat, fever and chills, lower blood count, rash, redness, blistering, peeling, or you get Steven Johnson syndrome rarely. That's why they're saying thoughts of suicide, bruising or bleeding. So just be aware. Diagnosed with ADHD is on methylphenidate. What are the about it? ADHD, child on methylphenidate. What are the side effects? Please type on your thing on the slido.com brain dash go to #brainstorm and give your answers. Very straightforward. These should happen just like that. These are the questions you will just sail through in the exam. These keep coming again and again. Insomnia, high BP, very good. Very common question. Anyone else? 8 people, or expect even if there are 6 people apart from me. So number 3. So what was 3? Just type the answer, no? It'll be easier, we can see. What is 3? Growth faltering. Okay. Anything else? Please do type. Get used to Slido because when you can see each other's answer, even if they're wrong answer, it doesn't matter. But then you see what is the way of thinking. Behavior problems, yes. So it is just about which one is the right one, really. But if it really help rather than being a spectator, please try, because see why we are doing this and why we are doing this and why I'm forcing you to type even if it's a wrong answer. Because in the exam, in the pressure of the time, you have to give an answer. Right or wrong doesn't matter. So I'm trying to get you used to committing to an answer. And then see where working because if you just the drink, you may think road that okay. That's the most caffeine loss, not weight gain. Headache, stomach pain, weight loss. We keep getting disconnected. Just hold on. Hope you can see it now. Yeah. So anyway, so we'll move to the next slide. And as you can see, there are two things you need to be used to: Ritalin and Concerta. Ritalin is methylphenidate. Concerta is methylphenidate extended release. Methylphenidate is used in ADHD, narcolepsy, age 6 plus. Concerta methylphenidate ADHD is used in ADHD, all ages, 6 to 65. Common side effects are decreased appetite, weight loss, growth suppression, insomnia, anxiety, restlessness, increased heart rate, increased BP, heart palpitation. So again, the same thing, all more or less same, increased sweating. You get increased sweating in this one, and upper abdominal pain. You don't get in the Ritalin. Risk of dependency, yes, schedule to control. So it is a dependency, because if the parents ask you, you have to counsel parents that it is a dependent medicine. So that is part of your counseling really. So if you get it in a in a question anywhere, whether it is whether you have to inform patients about his dependence. Yes, it is. Interactions, increased risk of serious heart problems and high blood pressure. That is the main problem. Okay, so I hope that was useful. Now, I did this because I thought this is very useful. A very quick look at the main drugs and their side effects. So if you go to the main ones, lamotrigine. Common is dizziness, blood vision, insomnia, even with lacosamide, dizziness, blood vision. These are very common, headache and all that. But lamotrigine, main thing is Stevens-Johnson. It is rare, but it is serious. So you have to be aware of it. Toxic. So all Stevens-Johnson and toxic epidemic failure, multi-organ failure, you have to use to that. Lacosamide is rarely used, but PR interval, atrial fibrillation, all hard, cardiac ones. Remember, lacosamide is cardiac problems, intervals, flutters, prolongation. Lamotrigine is more of multi-organ skin problems, Stevens-Johnson, toxic epidemic, but which are really severe. Now, levetiracetam is a commonly used drug nowadays. Fatigue, dizziness, these are common. Somnolence, irritability, but psychosis is the serious one. So you have to know the most serious ones. Psychosis is levetiracetam, lamotrigine, it is and cardiac lacosamide, PR interval, prolongation, atrial fibrillation. Now, oxocarbazine, again, dizziness, diplopia, blood vision, have common stuff, headache, Stevens-Johnson syndrome. So again, skin dermatology problems. Pregabalin, fatigue, dizziness, ataxia, common, but nothing, no other problems. I don't want to go in rufinamide. I don't think we do it very often, but shortened QT interval is the main. Topiramide is used, so you need to know stroke of the common ones. And drowsiness, word finding, difficulty, concentrating difficulty. These are the. Let's move on to the next one. And where do you use which basically antiepileptic, where do you use? So very simple. If you see, valproic acid is almost used everywhere. Primary generalized tonic-clonic, even if it is used in the first line I'm talking about, absence and atypical absence seizures, myoclonic. So valproic acid is first line in primary generalized tonic-clonic, absence and atypical absence. Second line, it is very further down the line in focal. Focal first line is camazepam, that is the main one, and phenytoin. Absence seizures, Again, second line is ethocyxamide, which you need to know, which keeps coming in the exams, and atypical absence, topiramide, and lamotrigine. This is where the fill in. Okay, so you need to live with that. A young boy with development delay on anti-epileptic drugs has muscle weakness and recurrent chest infections with a purpuric rash on the lower limb. He was a picky eater. What is the cause of his presentation? So just see this picture, very easy, and put your, you know, so I'd like you to put the Slido. Please go to Slido. What is the cause? So scurvy, yeah. So because it's very quick, you have to be very quick in the exam. That's what I'm doing. Time pressure now. It's no good giving a lot of time because in the exams you don't have time. Yeah, these things have to get very quickly. So please, more people try to join in. Please type in. It's very simple. As I said, I can't see who's giving the answer, so no, I cannot judge you, and I'm not going to say anything to anyone anyway. Please join slido.com, brainstorm, gum hypertrophy. That's good, you know. Where do you get gum hypertrophy, by the way? Do you know where do you get gum hypertrophy? Which medicine causes it? So you just see the answer. So it is vitamin C deficiency. So what do you get? Someone on anti-epileptic drug, muscle weakness, recurrent chest infection with a purpuric rash, picky eater, and then you got that answer. So you see the vitamin C deficiency tissue defects, you get corkscrew shaped body hair, poor immune function, impaired wound healing, red patches on skin, dry and rough skin, anemia, depression, and fatigue. So these are the ones you get on vitamin C deficiency. Now, I just thought you need to be aware, again, same as lower immunity, poor memory, infertility, these are in adults, breast and prostate cancer, infertility. Again, frequent cold flus. So in vitamin C, you had COX-2 here, and you had lowered immunity as well. Now, but again, zinc is associated with poor memory and slow thinking process. Fingernails, I think everyone knows zinc deficiency. Now, all of us know loss of taste and smell is very characteristic of zinc deficiency, loss of taste or smell. And again, sinus problems, that's why in colds we give zinc. Skin rashes, eczema, I think most of us are familiar. Loss of appetite, insomnia, low energy. Zinc has an important role. Okay. Now, baby 18 months old has been well, and there was decoration at home. So they had a Christmas celebration. So there were a lot of decorations at home going on. Presented with cough, wheeze, and decreased air entry on the left side. What is the diagnosis? Okay. 1, 2, 3. What is the chest diagnosis? These shouldn't take time, really. So please go to slido.com, #brainstorm, and I want to see how many of you are brave and go for it. Don't be a watcher. Don't, in your life, left foreign body. Very good. Be a participant. Don't just sit on the arena and see what others are doing. Join, it is better to, lose when you're in the arena. They say that better than being a spectator, be on the arena itself. That is more important. Okay. So right-sided foreign body, left-sided foreign body. So, you had a few answers there. What's the left side foreign body? Just see the picture. So obviously this is blackout, isn't it? This is left side, isn't it? This is left side foreign body. Yeah. So just look at it. Why left-sided foreign body? What happens to that side? Which side? You need to know which side it will be hyper expanded, which side will collapse. Just get an idea on that. Read about it in more detail. Okay. Left-sided foreign body. So obviously you will have decreased air entry on the left side. You will have cough and wheeze. Okay. Now let's go to the next one. What is congenital cystic adenosis? Because these were the choices. All was CM congenital cystic adenoid malformation. It is presenting as a cyst and presenting as a cyst in the USD. Okay, so that's a CT scan, and you can see the X-ray finding as well. And this is chemical pneumonitis is also another choice because you do get in the exam, a child might have, baby might present with aspiration. So see how it looks like. That is, and also chemical pneumonitis. Where do you get these more commonly? Aspiration, cerebral palsy children, child, someone who's allergic to feedings, swallowing disorders. So be aware of that. A lot of questions do come up on that one. Right. Next one. 4-year-old boy. Let me just check what the time is now. It's 9:51. 4-year-old boy had a mid-thoracotomy star presented with a temperature of 39 degrees centigrade, splenomegaly with pansystolic murmur, best heard on apex. What cardiac lesion is suspected? These are the choices. Just please type. Okay, these are things which you should be, they should be fairly used to. What is the cardiac lesion? These should be at the, it should be at least your way of thinking should be established by now. And just type only 1% type, but do type because VSD, mitral prolapse, tricuspid regurgitation. Because when you make the mistakes here, then only will, when you're in a group, we'll discuss the answer, then you will not make the mistake. That's why I say join here now, because you never make the mistake again. Let's get the mistakes out of the way. Let us correct each other. Okay, we are working here as a group, so we'll correct each other. Why obviously if you're getting the wrong answer, either you've forgotten or the way of thinking was not right. So VSD is, mitral prolapse, tricuspid regurgitation. It is mitral prolapse. Okay. Now let us come to the thing because I want you to see a few pictures. So what happens in this is a aortic stenosis. You get a sound in the systole, yeah, systolic murmur. Mitral regurgitation and mitral stenosis are different. So mitral regurgitation, you get a sound in the systolic murmur. It's almost like pansystolic. Aortic regurgitation, you get a sound in the systolic, diastolic. So diastolic is mainly mitral regurgitation. PDA is systolic and diastolic. Okay. So regurgitation, mitral regurgitation is mainly whole of diastolic. Mitral stenosis is also in the diastolic, but as I said, it has got more towards the end. And aortic stenosis is obviously systolic. So just be aware of this. Also, I thought how to quick, simple idiot's guide to murmurs. Systolic or diastolic murmur. If it's a systolic murmur, crescendo, descendo. Crescendo goes up and descendo goes down. Stenosis, aortic or pulmonary stenosis. Systolic means crescendo, descendo, aortic or pulmonary stenosis. And systolic, if it is going through holosystolic, means throughout the same, then it is some sort of regurgitation. So it is either a mitral or tricuspid regurgitation. So I guess those who put tricuspid, I guess you're right as well. Okay. Diastolic, early diastolic or decrescendo. So you get early regurgitation, aortic or pulmonary regurgitation. So diastolic, systolic is stenosis, aortic or pulmonary stenosis, and mitral regurgitation. Here you get so diastolic you get stenosis of mitral or tricuspid stenosis, and regurgitation you get aortic or pulmonary regurgitation. Hope that is very clear. Is mitral or tricuspid regurgitation. All right. And crescendo, descendo, aortic or pulmonary stenosis. So aortic or pulmonary, that is the systolic murmurs. Diastolic, early diastolic, so it's like a funnel shape. Early diastolic or decrescendo is going down. So aortic or pulmonary regurgitation. Aortic or pulmonary regurgitation. Mid or late diastolic is mitral or tricuspid stenosis. So obviously, we know that floppy mitral valve, it can happen in congenital anomalies like mitral valve prolapse. Now, match syndrome with the cardiac lesions. So you have to be knowing what is happening in Downs, what is happening in Turner's, what is in Noonan's, what is Williams, what is in Marfan's, what is fetal alcohol. So any idea what are the, what do you get with these? What are the cardiac lesions with Downs? Can anyone share? What are the cardiac lesions with Turner? This will keep coming up in the exam again and again and again and again. What do you get in Williams? What do you get in Marfan's? Any yeah, I think I want to see how many you get it right. So just write Downs with whatever. Then write Turn whatever. So then I'll know what you got tonight. Let's see. Let's see how many of us can get it right. So then you write, maternal and fetal. So if it is rubella, then what do you get? See how many you can remember. This is just a game. Take it as a game. This is how we are trying to rejig our memory. You never forget it this way. Never forget. How many can get? Marfan's, what sort of, just write Marfan's and by the side of it write what's the cardiac lesion. Turner's, what is the cardiac lesions? Okay. So we talked of Down syndrome, right? What is the thing? Turner's, Noonan's, fetal alcohol, maternal rubella. Down's AVST, most people got it wrong. Marfan's out is excellent. Turner's coarctation, excellent. Williams supravalvular aortic stenosis, Turner's coarctation aorta. See, this is very good, excellent. So let me see. Okay, someone is still typing. Very good. So, you'll never forget. This is the game. The reason why do I do all this? As I said, I could be doing something else right now. I could be watching Netflix, my favorite TV series, But why I'm here? Because this is fun. And I struggled during my exam because I found it so boring to study. But here we are trying to gamify it so that we enjoy it's fun. Remember it. Okay, very good. I'm really enjoying it now. Very good. So now we had record turnout. So a lot of people are typing. So Turner's coarctation aorta, Marfan's mitral collapse, Marfan's aortic regurgitation, Turner's coarctation aorta, Down's AVST, most people got it right. Turner's coarctation aorta, Williams supravalvular aortic stenosis. Okay. So let's see what's the matter. So obviously Down's is AVSD, Turner's is aortic. There are other as well, but I put the main one. Noonan's is dysplastic valves. Well, I think it is it's mainly a hypertrophic cardiac myopathy. And which dysplastic valve? I forgot to type it correctly. We'll see it in the next slide. Williams is supravalvular aortic stenosis. I think a lot of you got it right. Marfan's is William or mitral valve prolapse, regurgitation, excellent. Fetal alcohol is VSD. Just remember this one. Well, most of you don't know this. Maternal rubella, very important. PDA, dilated aortic root. Okay, but I think a lot of you got it right there. This is the actual thing. Down syndrome, AVSD, Turner syndrome, bicuspid hypertension, Noonan's is dysplastic pulmonary valve. I forgot to write pulmonary valve, but also hypertrophic cardiac myopathy. Williams is I think a lot of you got this right. Supravalvular aortic stenosis, PPS, okay. Marfan's syndrome is mitral valve prolapse and regurgitation, dilated aortic root. So dilated aortic root are getting in Turner and in Marfan's as well. Fetal alcohol is VSD, maternal rubella is PDA, PPS. Okay. And PPS is peripheral pulmonary hypertension, pulmonary stenosis. I was forgetting. PPS is peripheral pulmonary stenosis. Okay. So I looked at this chart and I found it very interesting. Very quick. Sometimes you may get questions on that. Cyanosis is obviously decreased pulmonary blood flow, like pulmonary influx, aortic stent like PDA or truncus arteriosus. Okay, just a quick thing. Again, this is very simple, but I found it heart murmur suspect is a new one. Yeah, so suppose you find a heart murmur suspecting congenital heart disease, and what do? You see a pediatric senior person has to review it, cardiovascular examination, pre and post ductal saturation plus minus ECG. Now, this is the question which will keep coming up in the exam. So you got a baby with a unstable baby, and you're finding a murmur. So how will you diagnose in a neonate, what to do next, whether to start on prostaglandin or what you'll do. So you do a pre and postductal saturation. I know you are waiting for the cardiologist and not yet come to echo. So how will you decide management? So pre and postductal saturation. So findings, any of the findings, signs of, if there is sign of heart failure, shock, lower limb saturation is less than 96% and greater than 3% pre and postductal difference, absent weak femoral pulses. There is significant congenital heart disease. So greater than 3% pre and postductal difference. Okay. Lower limb saturation less than 96%. So that is enough. Weak femoral pulses, significant congenital urgent. You need to put NICU, prostaglandin, inform the echo, cardiologist. And if it is a question of a loud murmur, heave, pansystolic, diastolic, continuous murmur, abnormal ECG, dysmorphic features, congenital heart disease, and soon you refer to echocardiography within a week and you go and echo. And if it is basically a well baby, no signs of heart failure, normal pulses, soft systolic murmur, only at murmur had a left systolic end, low risk of congenital heart disease. Okay, so I don't think that is a very important thing. Now, again, a lot of questions keep coming on MCQs and questions come on what is a normal murmur or, and what is a pathologic murmur, difference between innocent and pathologic murmur, which I want to go very quickly. So this is wonderfully given. This was actually done by in November 2009 by Sarah Parker. She was a student, so MD student, very well written. So obviously take a history. So approach to heart murmur of dyspnea, palpitation, exercise intolerance, dizziness, syncope, chest pain or exertion. Because even in clinicals, you will need this: dyspnea, palpitation, exercise intolerance, dizziness, syncope. So all cardiac features, chest pain. Physical examination, cyanosis, clubbing, weak or absent femoral pulses, capillary refill, increased precardiac activity, dysmorphic features, hepatomegaly. Now, any of these physical signs is pathologic murmur. What are the pathologic conditions? Okay, regardless, so any history, physical examination, these are all, pathologic. So on the right is pathologic and left is innocent. Innocent is systolic murmur, diastolic or holosystolic murmur is pathologic. Soft murmur is innocent. Harsh murmur is pathologic. Grade 2 or less is innocent. Grade 3 or harsh or higher one, possible thrill is pathologic. Exercise, anemia, fevers favors the innocent. If it is louder with exercise, anemia, and fever, but no change with position is pathologic. Others are no extra sound, but click or opening snap is pathologic, S3, S4. And normal S2, normal splitting, and whereas in pathologic, it is fixed split or S2. Must have all features to be innocent murmur, any pathologic features, even one pathologic feature is pathologic. Refer to cardiologist when there is suspected pathology cause or uncertainty, family history of congenital. If there is a family history of congenital heart disease or first relative, you have to refer to the cardiologist. Family history of Marfan syndrome or unexplained cardiac death in young person. So this could be an MCQ. When to refer to cardiologist? Known suspected chromosomal or genetic condition, trisomy 21. And if you get a request from parents with good reason. Anyway, so I hope that was useful. Now, this is again, I will put the recording on. Obviously, you couldn't see this in detail. I will put it in my Telegram group as well, Dr. Academia. You can see this very well given, So examples of innocent and pathologic murmurs. The green one is all the innocent murmurs and red one is the pathologic murmur. So central venous hum is innocent, cardiac groove, you can hear is innocent, peripheral pulmonary stenosis, here in the axilla is innocent, still murmur, left lower sternal pulmonary flow murmur is innocent murmur. You can see in the left upper sternal edge. Aortic valve stenosis is again, is not innocent. Pathologic VSD is the left lower sternal edge. And early mid systolic is harsh is a systolic ejection click, pulmonary valve stenosis, apex. ASD could be any age, and it is wide fixed splitting of second heart sound. Wide fixed splitting of second heart. So anyway, we'll move to the next one. Baby was with his grandparents as his mom was at work, and they noticed a swelling on his skull. X-ray was done. Now, what is the finding on X-ray? Just 1 second. I'm just don't know what happened here. Yeah. So this is the X-ray. Have a look. I'll only count till 5. 1, 2, 3, 4, 5. That's it. All right. Because in the exam, you won't get much more time. Either you know it or you don't. Right? So put your findings here. What was wrong? The more you practice like this with the time limitation, the more you will be good at the exam. You need to have the pressure of the exam. See, when you're studying at home by yourself, the TV is on, your friend is talking there, someone is making dinner. It's not the same thing. In the exam, believe me, the pressure, the stress, the time pressure, the environment, these are all high stress environment. And you have to get used to a high stress pressure, time pressure, where you can still concentrate and get your answer right. That's what I'm trying to do with you, with this, that is the purpose of doing this webinar, to see how you're doing here. Okay, so skull X-ray finding left parietal fracture. Anyone else? What happened? Others are not participating. Just write down something. What, anything? What could it be? It could be a fracture, isn't it? You could at least write fracture. In the exam, otherwise you won't get any marks. Something. Okay. As I said, I cannot see who's writing the answer, so I purposely made it that way so that anyone just write anything. Because you don't in the exam, you don't. There is no negative marking. So try, at least give a try. If you don't try, then that's it. You won't. There's no harm in trying. So as you can see, the X-ray. This is the parietal one. This is a fracture. This is the right side. This is the left side. This is the left parietal fracture. Okay. All right. Move on to the next one. A child. These are straightforward and simple questions. Child with acute lymphoblastic leukemia present with acute history of abdominal distension, generalized tenderness, and mildly elevated temperature. A picture of the child's abdomen was given. What is the diagnosis? So I'm showing you a picture. I'll give you till 5. It's very simple. 1, 2, 3, 4, 5. Okay. I'll let you go back to the question again. ALL patient, acute history of abdominal distension, generalized tenderness, and mildly elevated temperature. Picture was given. The choices are, you can see, and that was the picture. But again, I wanted to answer. So this was the answer, really. Sorry, I didn't give the answer anyway. Unless you got it. Did anyone get it? Sorry, I didn't give the this thing slide on this one, but this is Cullen sign. Anyone know what Cullen sign and Gray-Turner sign stands for? So Gray-Turner sign is a flank discoloration, late sign of retroperitoneal hematoma. Can be seen with hemorrhagic pancreatitis. And Cullen sign is periumbilical ekysposis due to retroperitoneal bleeding, can be seen in hemorrhagic pancreatitis, also ectopic pregnancy. Kerr sign is referred left shoulder pain due to subdiaphragmatic irritation. Okay, so let's do the next one. Preterm 25 weeks old presented with distended abdomen. X-ray abdomen was done. Let's see the X-ray. Wait 1 second. Just see the X-ray. Sorry, the answer came up, but just still see the X-ray. And can you see, your eyes have to catch up with this actually. Unless your eyes get caught up with it, it's very difficult. So I'll count till 8. 1, answer came up anyway. So I think you've seen the answer. 1, 2, 3, 4, 5. Anything? Can you put your answer in the? You can type it. If it's not there, you can acute pancreatitis. That was good. Deepa, you can use the question answer. You can type it on that. What about this one? What was there? You can use the question answer chat box. The Q&A box, and you can give your answer there. What was it? What was it there? So there was a. Did anyone get it? This is the one. This is the biliary gas. Portal vein gas. Sorry, portal vein gas. Okay, so it's a child, as you can see, you can already see he's got NEC, dilated bowels, thickened walls. And this is a portal one, which is a portal vein, which has got gas in it. So now I wanted to know difference between portal venous gas and pneumobilia. Okay, so portal venous gas is something which happens when you get ischemic bowel, NEC, intra-abdominal sepsis, NEC, gastroenteritis, umbilical vein catheterization, bowel surgery, all sort of things. Pneumobilious biliary tract infection, liver abscess, ERCP. Okay. And again, I did this picture because I thought it's useful. So again, portal vein gas, as you can see, the portal vein gas, this is where you get the gas. Okay. And necrotizing enteral colitis, ischemic bowel, perforated peptic ulcer, other things. But portal vein gas is for neonates, I think it is mainly NEC, what you need to know. Pneumovalent is this saying emphysematous cholecystitis, but there are iatrogenic causes, umbilical one aspiration and things like ascending cholangitis, trauma, other things as well. Okay. So just get some idea. Portal vein gas. No, basically see the diagnosis. But there is the choices, but just see the photo and tell me what it is and where do you get it. Sorry, the answer just came there. We're running out of time. So just type it, let us do the typing because I don't have the saying, sorry, I didn't put any more slides there. Just you can put under the question answer. So what is this? So metabolic syndrome, type 2 diabetes. Yeah, so basically it is insulin resistance, isn't it? 1 second. It is associated with insulin resistance, isn't it? Acanthasis nigrosus is insulin resistance. Okay, nothing to do with Addison's or all these things. Tuberous sclerosis. Again, these are the topics which keep coming in the exam. Tuberous sclerosis, neurofibromatosis, Addison's, Macklin. So please read in detail. A lot of questions you will come up in the next time. I'll do next week as well. You will get questions on these ones. All right. I will give you a lot of questions. So read these topics in detail. I will do another one next week. So be prepared that time. And I want to score highly on this, when we do this. So anyway, so you can see signs, symptoms and signs of acanthosis nigra. It has brown or black patches on the skin, mainly in the axilla, and you can get itching. It has bad odor from the side. It can also happen on the neck, okay, on the neck. And as you can say, you can also thicken, velvety, and relatively darker areas of skin on the neck, but also you can get it on the axilla, elbow, or on the umbilicus, genital area. So just be aware about that, okay? This is, I think, the last one. Case diagnosed clinically with, see, again, this is very easy, but it depends if you're not paying attention or not. Case diagnosed clinically with left hemiplegia, has a history of chickenpox 2 weeks ago. He can't walk and he has had tremors for 3 days. Which urgent investigation will help in the management? I will count till 5. 1, 2, 3, 4, 5. You can put your answers in the chat box, in the question answer box. Geeta, anyone, Tanushree, CT scan, yeah, Tanushree, Geeta, CT scan. Why? Why CT scan? Excellent. You're on the right track. Why? Because the complications of chickenpox include, so I put a comparison with shingles also so that you know. Because these two things keep coming in the exam. Encephalitis, meningitis, transverse myelitis, Rey syndrome. Shingles, encephalitis, meningitis, transverse myelitis, Zoster's, Ramsey-Hunt, post-herpetic neuralgia. Okay, be aware of that. This is a wonderful picture which I found. So you can see varicella, okay, latency, then it is failed immune control, virus reactivation. It happens in elderly, but then you get post-herpetic neuralgia, mainly in elderly people. Now, complications, rare in healthy children. It is rare, but the question can be on rare because it's a common condition. One of the hints for this exam is for common conditions like chickenpox or measles, be aware of uncommon complications. That's that's one of the things in the exam. Okay, you get very uncommon complications you have to be aware about because they're so common. So you can get sepsis, pneumonia, encephalitis, hemorrhagic complication. Okay, and you can see complications can also occur without rash. Meningoencephalitis, myelitis. So you cannot use. So as I said, that is zoster. and it might happen without a rash. Myelitis, cranial palsy, pancreatitis, hepatitis. Just be aware of that. So that was it really. So I hope that was helpful. Now, if you're at this thing, just give a feedback. Was it okay, good, bad? Just score on the, oh, good. So that was not bad. Anyone else want to give me a feedback? That would be great. We are finishing. I hope we didn't do too late. It is 9, it is 10:16. Okay, you're 67. Okay, so that's, thank you for that, because it's, that makes me feel that I want to do it again. We'll do it next week, okay? Next Wednesday again. And I'll make it, it will get better. I can promise you this one. We are working on this, and it will get better and better. Okay, so ask your friends to join, and we'll make it gamified so that it's fun and interesting. Now, what I want to know also is a feedback. So suggestions for next webinar, what you'd like to do, what you'd like me to do. Okay, this is the last slide really. So if we just put your suggestions, like would you like me to do a brain mind map, or any particular topics, or more dermatology topics, pictures, because the main thing here is to just do very quickly. So I thought of, my suggestion was, next time I'll do a lot of dermatology pictures, or a lot of MRI pictures, or a lot of retina, that sort of thing. But if you got any suggestions, or there's mind maps as well, at which I'll do at some other point. Okay, pharma and dermatology, yeah. Okay, so pharma, yeah, pharma is a difficult one, so you need to know really well. Pharma dynamic, yeah, that's, I think that is the right one. These are very boring. Pharma is very boring, but you get in the exam a lot of, and most people who have come back from the exam have said to me that, pharma is where they get stuck. And those people who got the pharma right, they scored high marks. Okay, so okay, yeah, X-ray, very good. And congenital infection pictures, yes. So you need to do X-rays. There are a lot of X-rays in the pictures. And I think what I'll try to do is DMSA, DTP scans. These keep coming in exams as well. Okay. For cardiac catheterization, data interpretation, you need to do the course, because that's where Deepa does it in detail, because that is very much concept related. ECGs, Deepa will teach in our course. That's in the Doctor Academia. It's an online course which you can join anytime. We deal with the difficult ones at that place. Okay, like cardiac catheterization data, capillary blood gas, and obviously much more detail. There's a lot of discussion, but at least here we will do the general questions. Most of the questions were taken from past papers. Okay, the ones I did today are mostly from recent exams. So you can imagine that it will come around these, and you have to be 200% sure about these questions so that you can sail through. So basically, dermatology and pharma, and you can see X-rays and MRI, congenital infection pictures. So thank you. Thanks a lot. Okay, so I'll just stop share now, and we'll finish it today. Thank you. We'll see you next week again. All right, same time. Okay.